Hello, and good afternoon. Welcome to this webinar about our project Identifying the Impact of Adult Social Care, or IIASC as we call it. My name is Julian Forder, and I'm the Director of the Quality and Outcomes Research Unit, and we run this IIASC project. So with me today I have Juliette Malley and Stacey Rand, and also Ed Ludlow. So the plan is that Juliette will present to you, as it were, on the webinar, an overview of the study and give you some details about what's involved. She'll talk for about 20-25 minutes or so, and then hopefully we'll have a chance then to address any questions you might have about the study and about what Juliette talked to you about. So before I hand over to Juliette, I'm just going to let Ed give you a few words about how this procedure might work and how you can ask questions and so on over webinars for those people who have not done this before. So Ed, do you want to just do that?
Hello everyone. Yeah, just following on from what Jules said, Juliette is happy to take questions as we go along, and you will have on your sort of the GoToMeeting information screen, there's a picture of a little hand. If you click that, you're putting your hand up, we'll get notification of this, and then we'll unmute people as and when we want you to ask a question. Juliette will then answer, and there will be sort of a more general questions and answer session at the end. Just to tell you, we are recording this, and it will be available on our website afterwards. We just have to make you aware of that. Hopefully that's it, and we're good to go. So I will now hand over to Juliette.
Do I put the presentation up? Sorry.
And hopefully we will start 3 minutes now.
Okay. Thank you, Ed and Jules. Yeah, so if you have any problems, if you can't see anything, then there's also a place where you can type a message, and if you do have any problems, please type something there, and Ed will hopefully be able to sort it out as this presentation is going along. So as Jules said, this is the second webinar that we've done in a series related to our project called Identifying the Impact of Adult Social Care, or IIASC. And what I want to talk to you today about is measuring social care outcomes, and setting it really in the context of the project, and in particular the Adult Social Care Outcomes Toolkit measure, which you're hopefully all quite familiar with since it's within the Adult Social Care Survey. Okay, so just an overview of the presentation. Everyone talks a lot about measuring outcomes at the moment. It's kind of a buzzword, has been for a while now, but I thought it would be useful just to start today by taking a bit of a step back and thinking about why it is that we actually go about measuring outcomes. What's the value of measuring outcomes, given it's actually quite a difficult thing to do? Why should we even bother trying to do it? Then I thought I would talk a little bit about, or describe, social care outcomes, how we define social care outcomes from the perspective of the development of ASCOT, the Adult Social Care Outcomes Toolkit. Then I'd like to talk a little bit about how outcomes data can be used within social care, in particular by local authorities. And that should lead us on quite nicely to talk a little bit about the IIASC study, what it is that the IIASC study is trying to do, in particular the value of the study, and what it is that we think makes IIASC quite unique and therefore a very exciting opportunity. I want to talk a little bit about the logistics, but if you, as I said, this is going to be a little bit, so if you want any more sort of detailed information, then hopefully you'll be able to ask questions at the end, and my colleague Stacey in particular will be able to explain to you exactly what it is we've been asking of local authorities to do to help us with this study. So that should be about 20 minutes, half an hour or so, perhaps a little longer, depending on how quickly I talk. And then it's over to you to ask any questions. Okay, so as I said, why measure outcomes anyway? Well, for me, the reason why you would want to go about measuring outcomes is because you want to get a sense of the performance of your organization, or perhaps the performance of a system. And there are three aspects of performance that I think it's really important to have an understanding of outcomes in order to be able to assess those elements. The first of those is quality. The second of those is efficiency and the related concept of productivity. And the third is equity. Okay, so why is it important to understand outcomes in order to measure these three aspects, or to be able to assess these three aspects fully? So what's just appeared on your screen, hopefully, should be a sort of simplified production process. So this is the process by which social care is producing outcomes for individuals. You take some resource inputs, this would be human resources, buildings, transport, consumables, so with different ratios depending on whatever the service is that you're talking about. And those inputs are converted to outputs, which are really sort of activity. So it's home care hours, daycare sessions, days in a residential care institution, and so on. But we don't have social care activity as an end in itself. It's not there for that reason. The reason why we put in place social care services is because we want to improve people's lives. We want to have a positive impact on the service users. So that would be the outcomes of the services. That will be what we were talking about when we talk about outcomes. So this might be things like improved quality of life, improved confidence. I'm sure you can think of many other different aspects. Okay, so why do we want to understand outcomes to measure these three elements? Well, if we think about quality, what we're really interested in when we're talking about quality is the effect that those services are having on people's lives, those outcomes. That's what we're really interested in. A good service should be one that means that people have good outcomes. It means that their quality of life is improved, their confidence is improved. But what quite often happens when people want to look at measuring quality is because it's very difficult to measure outcomes, people tend to focus on those things that are easily observable, that are easily measurable. They tend to focus on these aspects to the left, the resource input. So in the context of residential care, people might be looking at, say, for example, the quality of, no question? No, okay. The quality of the infrastructure, whether people have private rooms, how many private rooms there are, whether you know, the furnishings are looking nice. They might also be interested in whether the staff are well qualified. And whilst all these things, I think you can argue, might well be conducive towards high quality care, towards good outcomes, I think you'd be hard pressed to make the argument that they're absolutely necessary for people to have good outcomes. And even harder pressed to make the argument that they're sufficient condition for good outcomes. And you can think about this if you look at staff qualifications. Whilst it might, you know, whilst someone being very, very qualified may well mean that they're able to provide better care, equally I'm sure you can find people without any qualifications who are providing very, very high quality care for the people they're caring for. The second aspect I mentioned was efficiency or productivity. So again here, what tends to be the focus in terms of measurement is the relationship between those inputs and those outputs. So what you're incentivizing people to do by focusing on inputs and outputs is to maximize the outputs produced for a given level of input. So you're incentivizing people to focus on producing more and more home care hours and more daycare sessions for a given level of input. And you can begin to see again why this is a problem, why this is setting up the wrong kinds of incentives. Because, you know, 2 hours of home care for one person may be fantastic, and another 2 hours of home care for another person delivered by a different member of staff may not be so great. What you really are interested in doing, what you want to be incentivizing people to do, is to maximize outcomes for a given level of input. So you want to be including some sense of the quality of the care being delivered in your measure. The third aspect, equity, is a similar kind of argument to that around efficiency and productivity. What tends to happen is, again, outcomes are very difficult to measure. People focus on output. They're looking at whether people, given the same kinds of characteristics, the same kinds of background, are have the same access to services, whether they're receiving the same number of hours. But again, the same problem around equality holds. 2 hours of home care for one person may be fantastic. 2 hours of home care for another person may not be so great. So, there's not a sense of equivalence there, really. What you want to be looking at is equity in outcomes for people. Okay, so thinking about how we go about describing or defining social care outcomes in the context of the Adult Social Care Outcomes Toolkit. Where we started when we were thinking about this was trying to define what it is that we mean by social care. And I don't think this is particularly controversial, but do let me know if you have other opinions. Where we started was we said social care is usually for people with long-term conditions. Those conditions are often deteriorating over time. They're often multiple. And the important thing for social care, at least in determining needs, is that these often result in an impairment in activities of daily living, and it's that social care is really trying to help with. In terms of what's offered, social care tends to be a kind of collection of services and forms of support, but they're kind of united in 3 aims. And that's to maximise the ability of people to live independently, to help people to maintain their quality of life, and also to prevent or slow a decline in health. Okay, so how does social care go about meeting these aims? Well, I think there are 3 ways in which this can be done. The first would be by substituting for what individuals would have been able to do themselves. This would be the kind of classic home care services, care homes, personal assistance. Think of somebody who has kind of advanced emphysema, say. They're unable to really get around the home very easily by themselves, unable to move easily from out of the bed or from chair, walk around the home, walk around their home. What a personal assistant or a home care worker would be doing for that person would be helping them to get out of bed, helping them to get dressed, helping them, or perhaps even putting on shoes for them, doing up their clothes and so on. These are all things that the person would have done to themselves prior to the development of their condition. So what the service is doing is substituting for what it was that the individual would have done. The second area is by actually trying to improve people's ability to do things on their own. This is an area that I think you've seen quite a lot of advances or more interest in recently in social care. So in addition to sort of standard equipment and adaptations, there have been developments in terms of reablement services, and also perhaps thinking about telecare too. So what these services are trying to do is perhaps give people more confidence so that they feel more able to do some of these things by themselves. So for example, an alarm may mean that having just an alarm around the person's neck may mean that they feel more confident walking around the house because they know if they fall or something, they can easily press the alarm and there's somebody to help them. They won't be stuck in a very difficult position in a lot of pain for a long time. The third area, or the third aim that we mentioned, was around preventing avoidable health conditions. And the way social care goes about really meeting this aim is actually through meeting social care needs. So perhaps reducing isolation, taking people to day centres, getting them involved in clubs, helping them to reduce isolation and potentially development of depression. For somebody who's bedbound, it might be moving that person regularly. So you're stopping them or preventing them from developing pressure sores, which can cause many problems for people. Okay. So when I think about actually trying to measure outcomes, I think one of the most useful ways of looking at this, of thinking about what outcome measure is appropriate, is to think about the objectives of the service and what it is that you're actually trying to achieve. And when you think about the objectives of your services or even the social care system much more widely, there are many, many different objectives that you might be interested in. Those objectives can be very broad. So an example here would be maintaining and improving the quality of life of all service users that we're supporting in our local authority. They could be slightly more narrow and specific, so you might have identified a problem with pressure sores again within your home care clients, and you might be wanting to improve that aspect. You might have an objective around reducing the prevalence, say, of pressure sores in home care clients. Equally, you might have problems around hospital admissions in your area. You might want to be reducing hospital admissions by putting in social care support. Or when we're thinking about individuals, and perhaps in the context of assessments and reviews, these objectives may well be very, very personal, specific to the individual. So, for example, Mrs. Begg, she has lacks lots of confidence, particularly walking outdoors. Perhaps the objective for her is to improve her confidence so that she's able to walk outdoors and do lots of the things that she used to enjoy before she perhaps had a fall and that led to her lack of confidence. Okay, one of the questions that was asked before this session was whether we thought that the ASCOT measure of social care related quality of life, actually captures all social care outcomes. And I think our answer to this is yes, we hope it does. And I hope this slide is able to illustrate why we think it does. So this slide is adapted from a methods review for the School for Social Care Research, which was carried out by Anne Netton a couple of years ago now. And it's actually quite a useful paper for thinking about outcomes. If you're interested, there is a link to it at the end of this presentation. But what Anne did does in this illustration is separate outcomes, types of social care outcomes that there are, into different groups. So on the left-hand side, we have sort of some more kind of narrow specific outcomes. So we have what she labels intermediate outcomes, and these are really quite related to different types of services. So they're quite service specific. So they're around perhaps admissions to hospitals, maintaining people in their own homes. She also identifies what she calls personal abilities, outcomes around personal abilities and resources. That would be things like activities of daily living, communication abilities, confidence, and so on. You might also identify social care outcomes around the environment. So somebody, their home might be designed poorly, very difficult for them to get upstairs, pushing in a stair lift. That would be improving the design of the home. These would be, there might be outcomes then around the environment. Equally, there might be things around the accessibility of the local area, family relationships, and so on. There might also be outcomes that you're interested in around the quality of care, so perhaps around the relationships that people have with their carers, perhaps things around clinical safety, so for example the use of restraints perhaps within care homes. These things are very specific aspects that you may be interested in, that may be outcomes that you're interested in. But what this illustration tries to show is that whilst we might be interested in putting social care in order to have outcomes in all of these areas on the left-hand side, actually what we're trying to do through implementing social care and through getting outcomes in each of these areas is ultimately improve people's overall well-being. So if you think about an outcome around maintaining people in their own homes, actually our assumption behind that is that people prefer to live in their own homes. It's better for people to be in their own homes. Therefore, if we maintain them in their own homes, that's going to improve their overall well-being. And I think you can make similar arguments for all of these things that are shown on the left-hand side. The problem with trying to measure something like overall well-being, it's a very, very broad concept. It's quite nebulous. So what we set about doing when we developed the Adult Social Care Outcomes Toolkit, ASCOT, was to try and think about those aspects of overall well-being that would be most likely to be impacted by social care services. And what we came up with was this list of 8, and this was also influenced by talking to service users themselves, a lot of literature that there is around what it is that people value in terms of their quality of life, in terms of the outcomes from social care. And we have this list of 8 domains. The first is personal cleanliness and comfort, then there's food and drink, safety, clean and comfortable accommodation, social participation and involvement, control over daily living, occupation, and this 8th domain of dignity, which is really about the way the process, the way care is being delivered to you, and the effect that the way care is being delivered to you has an impact on your self-esteem. So one of the kind of quite unique things I think about social care is that often it's delivered on a daily basis, day in, day out. So it becomes very much a part of your life. The care worker, the personal assistant becomes, or even actually the item of equipment, becomes very much a part of your life. It becomes part of you in some sense. And that will have, in your use of it, will have an impact on the way you think about yourselves, and that's what we were trying to capture with dignity. I think there's one area that's kind of a notable omission here, and that was very intentional, and that was that we don't really have any aspects of kind of health. And there are a lot of health-related quality of life measures out there, and it was always our intention that this ASCOT measure would be used alongside those in order to give a much better sense of what it is that social care is doing. Okay. So one of the things that I would like you to take away from that illustration is the idea that you might want a different outcome measure for a different purpose. So the choice of outcome measure will very much depend on your objectives and how you're putting that measure to use, within what context you're putting that measure to use. So for example, broad outcome measures like ASCOT, like measures of other measures of well-being, are going to be much more useful for comparing across lots of different types of services, where a specific measure just kind of wouldn't cut it because it would be too specific to the way that service is being delivered, and those elements may not be present in other services. You're not really able to compare across them. So an example here perhaps would be comparing across daycare and home care and being interested in, the relationship with the care worker. And that measure is just not going to work for a day centre where you don't have that same relationship with individuals. These types of measures are going to feed much more easily into kind of strategic type of overviews, that type of work. Then you might have narrow outcomes that are going to be much more useful, as I just implied, for judging very specific services or elements of that service, and are perhaps going to be much more useful for thinking about operational action. So things that you might be able to identify from measuring an outcome very specifically, a way that we can improve services. So perhaps around something around, people's confidence or something within home care services. You can identify a very specific strategy you could put in place in order to improve that narrow aspect. And the third area, the third type of outcomes, will be the personal outcomes. And these are going to be much more appropriate in the context of kind of assessment and reviews. So using that information to judge how well the service has met the needs of a particular client. So very specific to individuals. Okay, and before I move on to talk in the next section, I thought it would be useful just to say something about self-report measures. So if I just flip back a couple of slides to this illustration of the different types of social care outcome measures, what I think you see as you move across to the right-hand side of the slide is increasingly the types of concepts we're talking about become much more subjective. There's something inherently subjective about them. Whilst I might have an insight into somebody else's well-being by sort of observing what they do, how they live their life and so on, I don't really think I can say, yes, it's great, or no, it isn't, without really asking them. There's something subjective. Subjectivity is important to assessment of quality of life and well-being. And when that's the case, then really you need to be relying on self-report measures. And that's great, I think, in the context of personalisation, because we want to be trying to make services meet the needs of people. We want to be trying to improve services in a way that matches with what people say matters to them. And that's really at the heart of these self-report measures, is that they're based on what it is that people are saying matters to them. However, this doesn't make them easy measures to use, and I think they're always going to raise some questions. One of the big problems there are, at least in the literature around self-report measures, is the issue of adaptation. So people, perhaps they have a trauma, and initially, immediately after the event, the way they judge their quality of life will be quite low. And partly the problem there is that they haven't adapted to their new circumstances, to what it is that they're able to do with their lives subsequent to the trauma. Over time, you may find that that person adapts, and they actually rate what is a very similar quality of life in a very, very different way. They rate it much more positively. You might argue that actually, well, this is a really good thing. What their overall well-being and so on. However, the problem comes, and that's fine when you're looking at individuals and their changes over time. However, it becomes a bit more problematic when you're interested in comparing across different people with different sets of circumstances. Because is it really, can we really say that somebody who has a much more limited ability to do various things, so, you know, they simply can't because of their conditions, say, go to the cinema, is there, maybe that's a silly example to give, but is their life really the same as somebody who has many more opportunities available to them? Is their quality of life really the same as somebody who has all those opportunities, even though they rate it in the same way? And this comes back to this issue of expectations and values. And people have very, very different expectations, very, very different values. And part of the way people judge their quality of life, their well-being, is dependent on those expectations and those values. And I suppose this problem will always kind of be at the heart of self-report measures. And whilst we might say subjectivity is really important, it does make us kind of question, I think, how sensible it is to completely rely on these types of measures when, you know, people have very different expectations and values. The other problem with self-report measures is that, you know, because we're asking people for their views, this is going to be very challenging to collect the views of people with cognitive and communication problems. And as I'm sure you all know, if you're involved to any extent in the adult social care survey, doing this type of work, collecting this type of data is resource intensive and extremely burdensome. So I think that really needs to be balanced. All these problems need to be balanced against the value that we get from them, which is really around understanding what it is that people say matters to them, the personalised aspect of the measure. Okay, so moving on to how we could go about using outcomes data. I think there are sort of 5 different ways, really, that you can think about using outcomes information in the context of your work. The first is kind of straightforward monitoring and assessing performance. There might be many different reasons you're doing that type of work. It could be related to contract monitoring. It could be more operational, talking about service improvement. It could be actually for staff development. There could be lots of different reasons why you're wanting to do that ongoing monitoring assessment. Then there is the idea that you can be using this outcomes information at a kind of higher, more strategic level to develop policy on perhaps a longer term basis, using information to identify problems, doing perhaps more research around the area, trying to figure out a strategy and a way of dealing with some of the issues that are developing. You might also be wanting to use the outcomes information to review individual progress. So at a very kind of individual level, looking at how it is that, say, a staff member or perhaps a service user, how they're developing, how their quality of life, how, you know, other areas are developing over time, and using that information to set goals for that person. The other area which it would be important to think about using outcomes information for is in the area of accountability. So really demonstrating that what you're doing through the delivery of social care services is adding value to people's lives and demonstrating that to the people who are paying ultimately for the service, which would be the service users on one hand, but also taxpayers on the other. And the 5th area will be around quality assurance and any activities that you're doing in that area. So perhaps, you know, around residential care and areas like that, outcomes information would be useful for those types of activities. Okay, but as I highlighted, I think very early on in this presentation in the first slide, there are problems using outcome measures. It's not easy to measure outcomes. And the reason why it's particularly difficult is the issue of attribution, or in English, demonstrating that the outcome measure reflects the impact of services rather than anything else. So just thinking about this issue in a little more depth. What we often are able to measure when we're talking about outcomes really is the outcome state of an individual. But what we're interested, what we really want to understand, is the effect that formal care and support services are having on that outcome state that you're observing. However, we know decades of research and just general sense will tell you that there are many other factors that are having an influence on that outcome state that you're observing. So this is shown by the green boxes. We've got elements that are capturing the characteristics of the person, so their abilities in terms of activities of daily living, dementia, all those aspects are going to affect the outcome state that you're observing for that individual. The environment that the person is living in. So say somebody living in a bungalow, somebody who has mobility problems living in a bungalow is going to have a very different outcome state to somebody with mobility problems living in a house with 1 story or even 2 stories and the only bathroom is upstairs. Or indeed their bedroom might be upstairs. You're going to see a very different outcome state for those individuals in those different environments. Another area that we know has an important impact is the informal care and support network of the individual. So people with very large informal care and support networks, they're going to have loads of people that they can draw on to help them. People with very limited or perhaps no informal care and support networks, which isn't uncommon amongst older people, are not going to have anyone to draw on at all. And the outcome state you observe for those people is going to be very different to the outcome state for people who have wide networks. And what we know from research is actually all these elements are more important in determining the outcome state than the effect of formal care and support services. And that's not because formal care and support services are doing nothing, it's just because there are so many of these other factors that they're kind of swamping the effect of formal care and support services. And just in the context of the IIASC project, I think it would also be quite useful to highlight here that there is also this relationship between informal care and support networks and formal care and support services and the impact on the outcomes of the individual and indeed the outcomes of the informal carers. Okay, so thinking in a little more detail and about how it is we might go about dealing with this attribution problem now we've identified it. We say that it's important to measure outcomes, so if we want to do that, we really do need to try and get a grip at least on this attribution problem to some extent. So I think there are 3 ways in which we can try to deal with this problem. The first is around our choice of measure. So if we come back to this idea of your objectives and your outcome measure wants to fit with your objective, again with the example of improving someone's confidence, if that's the objective, if that's what it is we're trying to do with the service, then let's choose a measure that most closely reflects that objective, that outcome that we're trying to achieve. So let's choose a measure of confidence, whether people's confidence, and see whether their confidence has been improved. That sounds very sensible, and sure it will work in some circumstances, but it's not always going to be easy to identify a measure for every single objective. The other issue with that is actually we're not completely resolving the problem. So despite being perhaps more certain that social care services are having a big impact on that outcome measure, we still know that all those other aspects, as I just flip back, all those other aspects are still going to be having an influence on confidence. There's nothing we can do about that. They're still going to be there. And the problem is if we don't try to at least get a sense of the impact of those other elements, we're not quantifying the problem. It's just kind of remaining there unresolved in the background. We're just assuming that it's not a big problem, and we actually don't know that, and we have no information to tell us whether our assumption is correct. The second way that you can go about dealing with the attribution problem is through method. The classic way, the kind of gold standard, is the randomized controlled trial. So in this setup, what you do is you've got your intervention, and you give it, you think, well, I'm going to give it to this population of people, and then you just randomly give it to half the people, and randomly another half of the people don't receive an intervention. They just carry on receiving their services as it used to be, and everything just goes on the same for those people. So why this setup is really useful is because by comparing the group of people who have been randomly selected to receive services and the group of people who've been randomly selected not to receive this new intervention, you can get a very good sense of what it is that intervention has done, what it is that intervention has achieved for those people. However, this type of method is not always going to be appropriate. It's not going to be appropriate for certain forms of, certain types of things. Say, for example, performance monitoring. You can't do a randomized control every month to understand the effect of your services on people. It's also only going to be really very sensible for very specific kind of types of interventions that you're trying to implement. And anyway, even if it is appropriate, given what it is you're trying to understand, particularly in the context of social care, there are a number of ethical, practical, not to mention financial challenges of implementing randomized controlled trials. So generally, this is going to be something that is going to be used really at the margins. It's not going to be a kind of main way of trying to deal with this problem. The third way of dealing with this, and I think the way that is most common, is through analysis. Now, the difficulty with using analysis in order to deal with this attribution problem is that you'll really need a lot of information in order to get a handle on it. So if I again just flick back to the last slide, what you want to do if you're trying to get a handle on the attribution problems with analysis is try and isolate, using all the data that you're gathering, the impact of formal care services and support services on outcomes. So what you want to do is measure the impact of all these other aspects, measure the impact of formal care and support services, try and put that together, perhaps through regression, in order to understand what it is that social care services are doing. There are perhaps simpler ways of doing that, so you might try and put local authorities or perhaps providers into groups that are similar in terms, again, of these characteristics. So they have people with similar needs profiles, they have people who have sort of similar environments, similar levels of informal care and support, put people into groups and then compare the outcomes across those groups. Whilst this is great in one sense in that it does give you a way into the problem and allows you to quantify at least the extent to which the outcome state that you're observing is due to services and due to other types of effects, there is always going to be some uncertainty remaining, because you're never going to be certain that you've measured all those things that are influencing the outcome state of the individual. And you also are relying on your data, and in some circumstances you won't necessarily have very good measures of things. The data might be patchy. Nevertheless, I think it's kind of the best way into solving this problem in this area. And that leads us into the IIASC study, because what we're really doing in the IIASC study is using that approach, the analytical approach, in order to try and understand the impact that services are having on people's ASCOT scores, their social care-related quality of life. Okay, so why IIASC? Just stepping back a little bit. The IIASC study was commissioned by the Department of Health as part of the Adult Social Care Outcomes Framework, the development of that Adult Social Care Outcomes Framework. The idea behind ASCOF is that the indicators should reflect the impact of social care. But as we've just been discussing, that's a very difficult thing to do. And certainly for the measures that come from the Adult Social Care Survey, those self-reported measures, what we find in ASCOF is that actually they're really capturing the outcome state. And as we've just said, that's problematic, and particularly is going to be problematic in terms of accountability. Should we really be judging or comparing local authorities on the basis of a measure that's not reflecting the impact of social care? Should we be doing that? Well, I think this is recognised certainly by DH and within ASCOF itself. And the aim of IIASC is really to improve ASCOF with that in mind, and to set about developing a value-added measure which is going to reflect the impact of social care better. Okay, so that idea in a bit more detail. The idea behind the value-adding measure, as we're seeing it, is that we will be able to generate it from the Adult Social Care Survey data with a simple algorithm. So what we're going to be doing in IIASC is doing a lot of analysis, different methods, different ways of going about it, to try and generate an algorithm that you can just apply to your data to give you a sense of the impact that your services are having on people within your authority. The algorithm is going to be based on the ASCOT measure within IIASC, so it's going to tell you something about the impact that you're having on people's ASCOT scores, on people's social care-related quality of life. So as I said, what the IIASC study is doing is developing that algorithm. It's testing lots of different ways of doing this, because there are different ways of doing this, and I think in order to be certain that you know, what we're coming up with is better and is going some way towards answering that attribution problem, we want to do this in lots of different ways. And we also want to explore the potential of this approach within the carer survey. Okay, so what will IIASC deliver for councils? Well, I think there's really quite a lot in IIASC for councils. First, as I've just mentioned, what we'll be trying to do is develop this value-added measure, this measure of impact. And the idea behind doing that is that the ASCOF and indeed the Adult Social Care Survey is going to be much more useful for policy and practice development nationally and, importantly, locally. Additionally, the information that we're collecting within IIASC will allow us to look at the effectiveness of services for the different groups of people that there are in our study. So for people with physical and sensory impairments, for people with mental health problems, for people with learning disabilities, and also for the carers of these people. And we hope that that analysis, that work, will be really useful for helping to inform policy and practice locally and nationally again. The third area, and I think this is probably the most novel and indeed unique aspect of the IIASC study, is that we're going to be collecting information from service users and also from their carers. And that's going to allow us to look at the relationship between outcomes for carers and service users and how services have an effect on outcomes for carers and service users together. This is very much a neglected area within research, probably because it's very, very difficult to gather data to do this, because you need to try and capture carers and service users, and they need to be linked in some way, and you need to have a good size sample to do it. So the hope is that this study will really help inform policy and practice in this very neglected area. And I've mentioned quite a lot of research that we're doing, and I guess one of the problems historically has been trying to get our findings from research into policy and practice. What we're doing within the study and what we've been working towards is working with two projects, MAX and SKEEP. So MAX is maximising the value of survey data in adult social care, and SKEEP is social care evidence into practice. So they're both really about trying to make better use of information and get the research that's going on into practice, into policy development. MAX particularly in the area of survey data. And we're working with them primarily to ensure that there's going to be impact from the study. So the research that we're generating is put into a form that makes sense, that kind of answers the questions that are going to be useful and relevant to you working within local authorities. Okay, so a little bit on logistics. This is a very broad overview. I don't really go into the details at all, so if you have more questions, then we'll be able to answer them later. So very broadly, what we're doing is we're trying to get a sample of 1,500 service users. That's the total sample that we're trying to achieve across the country. So we're trying to get a sample of 500, and that will be broken down. So we have 500 people from the physically sensory impaired group, 500 people from the mental health group, and 500 people from the learning disability group. And then we're also trying to get a sample of 500 carers, and they will be linked to the service users that we've got in our sample. So we'll be able to match the carers to the service users, and as I said, look at the relationship between outcomes for carers and service users. The data we're collecting is by face-to-face interview, and that work is being done by our fieldwork organisation, Accent. And within the interview, within the questionnaire, there's the ASCOT measure, and there's also lots more information about needs, environment, all those types of things that I mentioned that are going to have an impact on the outcome state. There's lots of information about those aspects in it. So what is it that local authority sites have been doing as part of this study? Well, primarily what we've asked local authorities to do is to draw the sample for us within their patch, to send out invites and reminders, and also to provide data from the records for only the respondent sample. So that's providing information about service use, about age, gender, so on, those types of things that you provide for the adult social care survey, but only for the respondent sample. So that can be quite few number of people if you don't get a very good response rate, or it may be more in authorities that get a good response rate. But at the moment we've been saying sort of the maximum of that would be around 150, although the actual size of the sample that you'd be sending out would be quite a lot bigger. In terms of the timescales, well, the study is ongoing. We started a few years ago now, I think actually, or a year ago now? A year ago now, with quite a lot of preliminary work. The field work has been ongoing since about May time. But there's still plenty of time to get involved in this study as the field work will be ongoing. Okay, so in terms of local authority participation, I think, as I said, there's really quite a lot in IIASC for local authorities. In terms particularly of the information that we're getting out from the study, it's going to be hopefully really, really useful. So we have a lot of local authorities already taking part, and we're extremely grateful to them for the work that they've been doing for us, sending out letters and helping us to recruit service users into the study. However, what we found, and this isn't unique to the IIASC study from talking to lots of other researchers, is that recruiting people for studies at the moment is really extremely challenging for some reason. And this is a shame, really, because what it means is that, we're sort of not quite hitting the achieved sample that we want from the study. And that will be a shame because if we don't get our achieved samples, because it will mean that we won't necessarily be able to do everything that it is we wanted to do in terms of the analysis, in terms of the output from IIASC. And obviously for people who have participated already, that will mean that we're not making the most of all the effort and everything that's been put in terms of the service users who put a lot of effort in terms of the local authorities who put a lot of effort in terms of our time, and also from the Department of Health perspective in terms of the money and everything that's been invested in the study. What we'd really like is for more local authorities to take part to help us to improve recruitment. So just kind of summarising that, I guess, what we'd like to ask from you today, if you're able, is to try and help the IIASC study. And if you're already taking part, then, fantastic, thank you, and do keep up the good work. It's been really great to see such enthusiasm from the local authorities who are participating. If you're not taking part, then it'd be wonderful if you would offer to be a site. We'd be very glad to speak to you after this, or to take any questions you might have about what that means. But also another way that you can help us is what we found from talking about the IIASC project over the last few months or so to people, is that a lot of people don't necessarily know about it or haven't really heard about it and what it is it's trying to achieve. And I think, as I said, there's lots in this for local authorities, and what we'd like for you to do is to in some ways be an advocate for the study and explain the value of it to other people, to the people you meet, and how it can help you in your day-to-day work. Okay, so for more information about IIASC, there's my colleague Stacey Rand's email address and phone number there, and also mine. We'd be more than happy to answer any questions you do have about the study. There's also a link down here to our profile. This is a short summary of what the study is about on our QORU website. And yeah, thank you for listening, and if you have any questions, I'd be more than happy to take them. And my colleagues.
The first question that's come in is
okay.
from Victoria Holt, and her question is, can you explain the relationship between this study and the zero-based review?
Oh, okay. I don't know if everyone heard that. So the question was around whether we should explain the relationship between this study and the zero-based review. We actually have someone from the Information Centre here who may be able to do a better job of that, or at least put some input into that, but I will try and take this. So the zero-based review is really around assessing the current data systems of local authorities and trying to make them fit better with what it is or the direction that social care services are going in, trying to improve the data set. Whilst this work is not directly related to the zero-based review, it's definitely in the back of our minds, in the sense that any indicator that's developed for ASCOF is going to have to take into account the types of information that local authorities are going to be collecting in the future. And what we've tried to do is future-proof this work in that respect, and to include within it lots of measures of the types of things that local authorities are going to be collecting in the future. I'm not sure that's a very good explanation of this, but essentially then they're not linked in terms of what they're trying to achieve, but we certainly are aware of the ZBR, and we are taking its development into account in the way we're thinking about developing our algorithms.
Hand up from Catherine Robbins.
Yes.
I'm going to unmute now. So Catherine, if you'd like to ask your question.
It's Catherine Robbins from the Information Centre here. I thought you might just want me to add something there. I'm not sure I've got a huge amount to add to what you've said, actually. Yes, indeed, on the zero-based review, we've now announced our new collections. That doesn't mean we've announced new surveys. There are lots of other things going on around the development of further things on the survey side of things separate to the zero-based review. Obviously, there is an ASCOF reference group, which indeed met yesterday, which looks at the future development of the adult social care outcomes framework and is well appraised of both the development on the survey side and on the activity, finance, safeguarding, collections and so on through the zero-based review. And they weigh up all the information, including the feasibility of what can be done given what councils are collecting in any given year when they make any decisions about proposals for ASCOF or think about any future work that might need to be done. I don't know if that helps at all.
I think so. Can you hear me as well?
Okay.
I think so. Thank you, Catherine.
Okay, thanks.
Are there any other questions? I guess that's it then. I don't know if Jules wants to say something now. Okay. Oh, hang on, sorry, we just had a question from Melanie. Can you say more about why the response to the survey has not been as good as you had hoped?
Yes and no. It's something that we've been finding across all the research that's going on at the moment, is that it's just very difficult to recruit people to this type of work. I mean, generally surveys, generally interview work, it seems to happen across the board. It's not a matter of what it is we're asking people, it just seems to be generally difficult to recruit people. I'm not sure why that's the case. Lots of people have lots of different ideas about why that might be. Perhaps we've seen a lot more research across social care, and that's happened to coincide with a time where services are being cut back and fewer people are receiving services. Perhaps people are hearing again and again. The same people are being sampled again and again. Certainly there is a lot more research across different areas, and perhaps it's all kind of coming together and that's having an impact. I think that's the kind of closest we can come to having some idea as to what it is that's going on. But it is definitely something that's been found, and there's not really anything that we're doing that is having an impact at all. I mean, we know that certainly doing things like following up definitely helps with response rates, and where we've done that we have seen improvements in response rates, but obviously we have to balance that against what it is that local authorities feel are comfortable doing from an ethical point of view, and what it is that ethics committees feel comfortable doing. So obviously, we don't want to overly pressurise people. That wouldn't be what we're about or what research is about. But it does seem that it's just something that is happening everywhere, really, and not unique to this project. Does that answer your question, or did you have anything to add?
Melanie, if I'll unmute you now, so if there's anything you would like to add to that or any further questions, go ahead now, please.
No, that's fine. I mean, I was wondering whether it was likely to affect the actual the adult social care survey as well going forward, and whether that's something you've noticed for the next survey, as you say, because the same people are taking part every time, whether that's going to actually impact next year as well.
I don't think this study is going to have an impact on response rates for the adult social care survey. I can see that happening, that this could have such an impact by itself on that. It may well be that taking everything together, that is the reason why we do see response rates falling year on year. But, again, it's quite difficult to answer that without, doing some analysis and looking at how frequently people are being invited to take part in the survey, and, whether those people who ask more often are less likely to respond in future surveys and so on. I think actually Stuart, I don't know if you know Stuart from Camden, just trying to think of his surname. I think he has done a little bit of analysis around this, and it does seem to imply that people who are asked a lot of times they're more likely to respond compared to other people when you look at them across all the surveys. When you look at them within a specific survey, they're less likely to respond. Is that clear? You see what I mean?
Yeah.
Actually,
yeah.
kind of continually asking them means they'll respond at some point, but yeah, otherwise.
Yeah,
no.
no, I get it.
think there is something going on there, but as I say, I don't think it's about this study or the adult social care. I think it's just accumulated everything that's going on.
Yep,
I think it's
fine.
also worth saying, sorry, that we've always expected that the response rates would be low, and we are asking quite a lot of people to take part voluntarily in these things, and that's why it's important to try and approach as many people as we can in the expectation that response rates won't be high. And obviously, overall, the goal for us is to try and get as many people as possible taking part, because the greater the number, the more reliable are the results of the analysis. And that's why we're trying our best to work with social services, with local authorities, with providers. We're looking at a whole range of different methods by which we can try and ascertain the views of people involved in the study, and taking a whole range of different approaches in that respect. So all of that is geared at trying to improve the numbers of people that respond, and so the reliability of the results.
Hope that answers that, Melanie. Any more questions from anyone else? Raise your hand now. I'm guessing that's it then.
Or if you have if you're interested in following up or want more information, either now by raising your virtual hand, or by following up with us, any of us in the team, then please do so. Be delighted to hear from you. I think we're good. Okay, so thanks very much for taking the time to listen to the presentation. I hope it was rewarding and over your lunchtime period. And thanks very much to Juliette for giving a presentation. And we hope to hear from some of you. Thanks very much. Goodbye.